so much for this opportunity. And this is my first time presenting at the IFAD, and I'm very excited about talking to you about a topic that's very close to my heart. What is the best fluid in intracranial hypertension? Although I have a few disclosures, none of them relate directly to the content that I'm going to present today. So let me just dive into the topic by sharing what I think are the principles of neurocritical care. And the true principles of neurocritical care start with patient-centered care, closed-loop communication, excellent teamwork that's going to help us recognize rapidly what is that primary neurological injury that our patient is suffering from, how do we prevent secondary neurological injury, and throughout this process, keeping the patient at the center, being really kind and thankful to one another. So here's a picture from my ICU. We have a couple of our fellows. One of them is a neurocritical care fellow. The other is a critical care medicine fellow. Our neurosurgery resident and one of our neuro ICU attendings together placing an EVD, and the two fellows here placing an arterial line in a patient who presented with high-grade subarachnoid hemorrhage, Hunter S5, modified Fisher 4, and he's in a coma. So when you see this kind of patient, what are you going to use as part of your first line of treatment for treating this suspected raised intracranial pressure? Of course, like all emergencies in medicine, ABC is always going to come first. And as we're securing this patient's airway to make sure that this patient is not going to suffer from secondary neurological injury, using some hyperosmolar therapy, even as part of your induction, as you're preparing this patient for securing their airway, is something that we have been doing very consistently. So ABCs is always going to come first. Then why is this patient in a coma? And what are the things that we're really trying to prevent by using one or the other hyperosmolar therapy? We know that there's decreased cerebral perfusion because of a sudden increase in ICP. And at the same time, we know that there is an underlying aneurysm that is unsecured. So we're not going to be able to press this patient. We're going to need tight blood pressure control. There's obstructive hydrocephalus. So we're also going to need, in addition to our hyperosmolar therapy, we're also going to need diversion of CSF and several other things that need to happen in parallel as we're administering either mannitol or hypertonic saline. So in the next few slides, I'm going to do a quick rapid review of some fundamental concepts for ICP, and everyone's really familiar with this Kelly-Monroe doctrine, intracranial compliance, what is cerebral perfusion pressure. CPP is equal to MAP minus ICP, your mean arterial pressure minus your intracranial pressure. So a lot of our therapies are fine-tuned to maintain that CPP. And recognizing who is having an ICP crisis. Of course, we can do this by way of clinical features, radiographic features, using invasive as well as non-invasive techniques. And simplistically speaking, the Kelly-Monroe doctrine really refers to having this blood volume, both the venous and arterial volume, brain volume, and cerebral spinal fluid, or CSF, all present in this tight compartment, the skull. So in a normal state, there is homeostasis, but as we're beginning to see increase in any one of these compartments, whether it's a mass lesion or whether it's, for example, a clot within the venous sinuses or sinus venous thrombosis, or you're beginning to see an intracerebral hemorrhage, there is going to be a point till which our brains can compensate, beyond which our brains will reach a decompensated state. When you think about cerebral edema, there are lots of different types of cerebral edemas. There's cytotoxic cerebral edema when cells are dying, vasogenic edema, which is breach in the blood-brain barrier leading to leakage of fluid around vasogenic edema, particularly seen in patients who have brain tumors, interstitial edema when there is an obstruction to the flow of CSF, so you're seeing this transependymal flow, or you may end up seeing a combination of all of these different types of edema. But does it mean that every patient with cerebral edema is going to have raised intracranial pressure? Perhaps not. It's very important to keep in mind that this compliance and how quickly, so over what time is the intracranial compliance changing, that's going to dictate what therapies we're going to use, as well as whether our patient is going to become symptomatic from these increases in volume contributing to increases in ICP or not. And quick recap of what a normal ICP waveform looks like. You have the P1, P2, and P3, and P1 will coincide with a percussion wave of your arterial line or the arterial upstroke. P3 essentially coincides with a dicrotic notch, and P2 is that tidal wave that's coming from the ventricular system. So if your P2 is higher than P1, it indicates that cerebral compliance is compromised or intracranial compliance is compromised. Everyone's very familiar with tiered management of ICP, and in all these different tiered management strategies, hyperosmolar therapies have been an integral part of the management. And when we look at this very recent guideline statement that was published after the International Severe TBI Consensus Conference, they do a very nice job of tier 1, tier 2, tier 3 for severe TBI. Similarly, where I trained for my fellowship at Columbia, we used to use this stepwise protocol, which we've adapted to my current practice as well. I'm a faculty member for MCRIT, a popular blog on emergency medicine and critical care. And I recently wrote my first blog post addressing this very topic, hyperosmolar therapies, and how do you choose which therapy and why. So let's do a quick recap of what our blood-brain barrier looks like and how is this different as compared to circulation in other parts of the body. So capillaries in different parts of the body do not have these tight junctions, but at the level of the brain, our capillaries have these tight junctions which really control this movement of ions and molecules in different cells. So what ends up happening when we're using hyperosmolar therapies, we're really relying on creation of an osmotic gradient. And depending upon the therapy that we're using, whether it's Mannitol or whether it's hypertonic saline, essentially we're relying on the reflection coefficient to determine whether something's going to be permeable through this blood-brain barrier or not. As an example, Mannitol has a reflection coefficient of 0.9, sodium chloride of 1. So it's not like either of these are penetrating this blood-brain barrier. There are several similarities in the mechanism of action of Mannitol as well as hypertonic saline, because they're both going to rely on creating this osmotic gradient and dehydrate the brain by sucking out fluid, edema from neurons. And by reducing blood viscosity, by either using hypertonic saline or Mannitol, what we're essentially doing is, again, potentially causing some cerebral vasoconstriction. And this cerebral vasoconstriction will in turn lead to decrease in intracranial pressure. So thinking about that compensated state where a raised ICP is not going to cause symptoms, we are relying on some of that cerebral vasoconstriction. Similarly, when we hyperventilate our patients, we're expecting that CO2 to cause cerebral vasoconstriction, thereby help in reducing ICP. And overall, because of this hypertonicity, both Mannitol and hypertonic saline also promote the reabsorption of CSF. Let's talk a little about Mannitol, and then we'll talk a little more about hypertonic saline. So what is Mannitol? So sugar versus salt. So essentially, this sugar is a naturally occurring sugar alcohol. It's an isomer of sorbitol. It's available commercially as a white crystalline powder, and it could either be in a granular form or it could be available by way of sterile solutions. In the United States, we have all these different concentrations available, 10%, 20, or 25%. And what we end up doing is usually administering Mannitol as a bolus by way of a peripheral IV line. But typically, the Mannitol dose that we're going to administer needs to be administered by way of a filter. And there's also risk of causing phlebitis if these filters are not used. So essentially, using a dose anywhere between 0.5 to 1.5 grams per kg. Some guidelines also talk about a slightly lower dose, 0.25 grams per kg, right up to 1.5 grams per kg, used as a bolus dose via a peripheral line. So as you're administering Mannitol, what do you really need to monitor? So our typical, for all these patients who have raised intracranial pressure, who have cerebral edema, as we're monitoring them, currently at my hospital and health system, we do basic metabolic panels for their sodium checks, Q6 hours. So every 6 hours, we're going to check their sodium. Every 6 hours, we're checking their osms. We're going to calculate their osmolar gap. And if that gap is lesser than or equal to 20, we're going to redose Mannitol. Now, in terms of the onset of action, Mannitol's onset of action is about 10 to 20 minutes. The peak is going to be seen between 20 to 60 minutes, and the effect is going to last anywhere between 4 to 6 hours. So typically, you're going to need to redose Mannitol. There are several adverse effects that you can see with Mannitol. because it's acting as this osmotic agent, even at the level of the brain, it's doing the same thing at the level of the glomeruli. So it's going to cause there is a potential to cause acute kidney injury because it's going to prevent reabsorption of sodium and water at the level of the glomeruli. And you can also see hyponatremia, you can see hypokalemia, various kinds of electrolyte imbalances. And because there is this intravascular volume depletion that mannitol can cause, if you do not replace that volume using an isotonic fluid, for example, using either isolite or plasma light, you're going to potentiate hypotension and thereby compromise cerebral perfusion pressure. For patients with pre-existing end-stage renal disease or patients who already have some kidney injury, should you really use mannitol or not? So there are small studies that have looked at the safety of mannitol in those patients, and it has been found to be. So let's move on to hypertonic saline. What are the key differences between hypertonic saline and mannitol? The onset of action with hypertonic saline is going to be as fast as 5 minutes. The duration of action is going to last much longer, as opposed to the 4 to 6 hours with mannitol. The duration of action for hypertonic saline is going to be all the way up to 12 hours. The other key advantage is you're not going to see a rebound increase in ICP after this effect wears off. So we're getting this sustained effect, we're getting a quick effect, and we're also not seeing rebound increases in ICP. The other thing that can be seen with hypertonic saline is some anti-inflammatory properties as well, because of restoration of the glycocalyx of endothelial cells. We're also not going to be worried about hypotension with hypertonic saline, because you're going to get some positive inotropy. You're going to see an increase in mean arterial pressure. Except, and I will give you that caveat on the next slide. So overall, what we're experiencing with hypertonic saline, there are some key advantages as compared to mannitol. So for 2 to 3% sodium chloride, you can administer it safely. There are several studies that have shown that it can be administered safely via a peripheral IV line. But for higher concentrations, a central access is recommended to prevent phlebitis. Lots of things to monitor for, again, just like we mentioned for patients who are getting mannitol therapy, monitoring their basic metabolic panels for their sodium every 6 hours, the osms every 6 hours. There can be several electrolyte imbalances, hypernatremia, hyperchloremia, non-anion gap metabolic acidosis. You can also see acute renal failure. You can see hypovolemia and all the other problems that come with hypovolemia, right from flash pulmonary edema to heart failure exacerbation. Just overall volume overload is a definite thing to watch for when we're using hypertonic saline solutions. So caution is advised when you're using a super concentrated dose of hypertonic saline at 23.4%. These 23.4% bullets, as we're administering them, the typical rate of administration is about over 5 to 10 minutes. I usually advise my team to keep pressors ready at the bedside, because we don't want to induce secondary neurological injury as we're administering that hypertonic saline, because your patients can become transiently bradycardic or hypotensive because of this vasodilatory effect of that concentrated bullet. So how do I choose between these two? What am I going to use? It really depends on the underlying etiology. What access do I have? And then what is available in that care setting? So for the most part, in my hospital and throughout my health system, we know that mannitol is very easily available. In our neuro ICUs, we have 23.4% very easily available. So sometimes it's also a matter of what is available to you. And as you're beginning to treat someone's raised intracranial pressure, making sure that you parallel process and you're using the right dose with the right access. Just a quick snapshot of what are the typical osmolarities that we're seeing in these different solutions. So as an example, with mannitol, for 20% mannitol, the osmolarity is upwards of 1,000 millimoles. And then for 23.4%, it's 8,000 millimoles per liter. So it's a very, very concentrated solution. There are several guidelines that have addressed how to use different kinds of hyperosmolar solutions. However, all of this literature shows us that there is a dearth of high quality literature. There are very few randomized controlled clinical trials that have compared these therapies head to head, but particularly for TBI. So the Brain Trauma Foundation guidelines go back to the third edition, because they did not find studies that met the criteria that they had set out for providing recommendations in the 4th edition. So essentially what they're saying is, yes, you can use mannitol, but prevent hypotension. The recommendations from the American Heart Association on cerebral and cerebellar infarction with swelling also does a quick summary of the different studies that have looked at, the few studies that have looked at this head-to-head comparison. And what they recommend is, again, use of hyperosmolar agents is recommended, but not prophylactically. And the most recent guideline statement comes from the Neurocritical Care Society, looking at hyperosmolar therapies. Key considerations, of course, monitoring renal function, osmolar gap, making sure you have the right access, and avoiding systemic hypotension, hyponatremia. And what they also say, there is insufficient evidence to recommend a continuous infusion, as well as recommending specific targets. So summarizing what these guidelines say for different diseases, for subarachnoid hemorrhage, again, symptom-based treatment, no doing prophylactic treatment with hypertonic solutions, and specifically for acute ischemic stroke, hypertonic saline solutions as well as mannitol are both efficacious, so you could choose what you have available. For TBI, hypertonic saline, there was a recent systematic review as well, which shouldn't say recent, it's actually 4 years old now, but hypertonic saline is better than mannitol. For ICH, again, hypertonic saline better than mannitol, and then for hepatic encephalopathy, they're both equivalent. So what is the bottom line? The bottom line is we've got to choose the right dose, the right route, and we've got to monitor our electrolytes and osmolarity. Keeping in mind that raised intracranial pressure or a suspicion for raised intracranial pressure, irrespective of how you're suspecting it, whether it's by way of clinical features, radiographic features, or you have invasive or non-invasive ICP monitoring devices, using hyperosmolar therapies is only one part of everything else that you're going to do for this patient. Right from managing their ABCs to at every single point in time asking whether there is any role for neurosurgical intervention or CSF diversion is going to be imperative. And overall, just to simplify everything based on current evidence and guidelines, it's reasonable to use hypertonic saline over mannitol for all acute brain injuries. And in the event that you do not have hypertonic saline available, sodium bicarbonate could also be used as pushes. So with that, I'd like to thank the IFED, and I hope you enjoy the conference. I'm looking forward to learning a lot. And this is from my ICU during the first peak of COVID-19. These are pictures without masks before COVID-19. These, of course, are after COVID-19. The camaraderie, the collaboration did not change. It only got amplified. And that's my contact information and Twitter handle. Thank you.